So first of all, it's a great pleasure to be here at TAMEST. Somebody mentioned yesterday that this is the brain power of Texas, and it seems that way. And it's a great privilege for me to be here, and I look forward to your feedback on my research. So kidney cancer. So it's the 7th most common cancer in men and the 9th most common in women. There are over 60,000 new cases in the US every year and more than 200,000 worldwide. Approximately a third of patients will present with metastatic disease, and another third will develop metastases after surgery that removes a kidney tumor. And despite recent therapeutic advances and the approval of several new drugs, this remains largely incurable. For reasons we don't understand, the incidence of kidney cancer in Texas is higher than in many other states, as you can see here. Maybe this looks like one of the obesity maps that we saw yesterday. And in fact, kidney cancer is the 6th most common tumor type in Texas. Interestingly, at UTSW and the Simmons Cancer Center, kidney cancer is the 4th most common tumor type that we see, with a total of 330 patients recorded, or almost 230 patients in 2012. This led to the creation of a kidney cancer program, which was founded in 2013. And here you can see Mayor Rawlings, who did the inauguration on December 8th. So renal cell carcinoma is thought to arise from the cells lining the nephron. The tumors are typically characterized by 3,000 to 6,000 mutations, which is not uncommon, about 1 to 2 mutations per megabase, but the majority of these mutations are passenger mutations. There are approximately 5 to 10 drivers. So when with a localized tumor, the classic triad of blood in the urine, pain, and feeling of a mass is infrequently seen, and most patients will have no symptoms. The tumor can spread both through lymphatic vessels as well as blood vessels, and of course that leads to metastases. What you can see here is a CAT scan from a patient of mine. If you're not used to seeing the type of scans, the patient is lying on his back, and you can see this is the normal right kidney. This is a large primary tumor on the left kidney. And kidney cancer metastasizes most commonly to the lung. You can see here a lung metastasis. Then it also has a predisposition to go to the bone. And if you follow the cortex of this femur, you can see that it's eroded over here. And this lytic metastasis from kidney cancer can cause fractures. Kidney cancer will also go to the liver frequently, and less frequently, but causing a lot of problems, it may go to the brain. So importantly, biological understanding, as we heard earlier today from Fred, has led to new treatments. You can see here a list of 7 new treatments that have gotten approved since 2005. I would like to point out that up until 2005, there was a single treatment approved by the FDA for the treatment of kidney cancer, and that was interleukin-2. So there's been a lot of progress. Now I'm going to switch gears because I want to present a case to you. So this is a patient that I saw a few years ago, 24-year-old man who has a familial condition, tuberous sclerosis complex. And he comes here with this enormous recurrent tumor that is in fact taking up most of the abdomen. You can see an abnormal kidney on the other side. The patient is transferred from an outside hospital, and this is a recurrent tumor. It's an epithelioid angiomyolipoma. This is not a renal cell carcinoma. This is an unusual tumor type. This is just what the cells look like when you look at them under the microscope. 5 months earlier, he had had a right radical nephrectomy, a removal of the tumor in the right kidney, which had shown an epithelioid angiomyolipoma which had spilled. The tumor was profusely bleeding, and his red blood cell count was approximately 25 to 30% of normal. He required 6 to 8 units of blood when he came in. There was an attempt to embolize the arteries feeding the tumor that failed. He was unable to tolerate oral nutrition, and he started intravenous nutrition, and he was very deconditioned. So what were his options? The surgeons looked at him and said, this is not somebody we can operate. This is a tumor type for which there is no systemic therapy proven to work. So what was recommended for this 24-year-old patient was hospice. Now, I mentioned to you that this patient had familial tuberous sclerosis complex, and this is a genetic disease that is caused by mutations in genes that encode these proteins, the TSC1 and the TSC2 proteins. So in this case, the expectation was that these proteins were not functional in the tumor, and I'm going to show you some data that supports that, leading to activation of this complex, mTOR complex 1. And we have a very specific, in fact, an allosteric inhibitor of this complex that would be expected to restore the balance. So with this data in hand, I spoke with the patient and his father. This is a biopsy of the tumor, and you can see this brown staining, which is indicative of mTOR complex 1 activation. And I recommended that we started this treatment empirically. There was no prior report in the literature of patients with an epithelial angiomyolipoma being treated with sirolimus. So this is what happens. When the patient came in, he had a very low hemoglobin. As you can see, he was transfused with the order of, so initially 7 units of blood and then 6 units of blood. Hemoglobin was going up and down. The embolization didn't help. He started sirolimus. His hemoglobin has stabilized. He required 1 additional transfusion. And that scan that I showed you was from February 2009. And this is a patient that was going to be going to hospice. And I'm going to show you a different scan. And this scan is from April of 2013. So this is a patient that survived over 4 years with a very well-tolerated mTOR complex 1 inhibitor. This stage, you can see the tumor is much smaller. And this is actually a second tumor that arose from the prior tumor that eventually ended up taking the life of the patient. We tried to do surgery and remove it, but it was not possible. And this was a tumor that was resistant to the mTOR1 inhibitor. But what were the keys to success? Well, we knew the genes that caused the tumor. We understood how those genes alter signaling pathways leading to tumor development. And finally, we had a drug that allowed us to intervene. So these are the pillars for my laboratory. Where do we want to go? We want to develop personalized medicine. Where do we need to start? We need to start by understanding the genetics. We need to know how mutations in genes affect cellular signaling pathways. And we want to use that knowledge, as we saw beautifully described in the first talk this morning, for drug development. Now, that's not enough. We also need animal models, biomarkers to determine what is the state of the tumor in the patient, and eventually clinical trials. So this was the pillar for, or those were the pillars for the research program in my lab. So let's go back to now renal cell carcinoma. As I mentioned before, epithelial angiomyolipoma is not an epithelial tumor type. So the most common type of kidney cancer is the clear cell renal cell carcinoma, and this tumor is characterized by mutations or inactivation epigenetically of the Vhl gene, the von Hippel-Lindau gene. Clear cell renal cell carcinomas account for approximately 75% of all renal cell carcinomas. So this is a very simplified schematic here of a renal tumor, of a clear cell renal cell carcinoma. The Vhl gene is inactivated, as we discussed, in the majority of tumors, and this leads to constitutive activation of a protein, hypoxia-inducible factor, in fact, a family of proteins, which stimulates, among others, the secretion of angiogenic factors, which will recruit blood vessels and nurture the tumor. And this has led to major developments in the therapeutic arena. We have now humanized monoclonal antibody that targets VEGF. And in fact, you cannot see it here very well, but if I change it, maybe we'll have problems with the computer again. But multiple drugs that target the VEGF and PDGF receptors. This work that I did as a postdoc and that others did linked the second pathway with hypoxia-inducible factor that governed by mammalian target of rapamycin, specifically complex 1. And we have 2 different drugs that target this complex. So the developments in renal cell carcinoma have occurred as a result of a greater understanding of the molecular genetics and the biology of kidney cancer. Now, what we need going forward, we need to identify new genes, and we need, and unfortunately you cannot see these, better ways to target other proteins along the pathway. So this study, and I highlighted here Andrew Frutrial, who is a protégé at the meeting, that reported the discovery of mutations in the polybromo1 gene in clear cell renal cell carcinoma. So polybromo1 was found to be a 2-hit tumor suppressor gene. Mutations abrogated protein expression. Mutations were found in nearly 50% of clear cell renal cell carcinomas. Polybromo1 encodes a protein, BAP1, which is a component of a nucleosome remodeling complex and is thought to regulate DNA packing and accessibility. Now, my lab discovered another gene that is mutated in clear cell renal cell carcinoma. That's the BAP1 gene. We found that BAP1 was mutated in 15% of sporadic clear cell renal cell carcinomas. Most mutations in BAP1 abrogated protein expression. BAP1 is a nuclear deubiquitinase and has been implicated in several biological processes, including cell cycle regulation, DNA replication, and DNA damage repair. And we found that BAP1 mutant tumors tended to be of high grade and associated with activation of mTOR complex 1. So here you can see the list of 176 tumors that we examined for BAP1 and PBRM1 mutations. So all of these tumors here have mutations in polybromo1. And then here, starting at this tumor, number 40, you can see tumors with mutations in BAP1. The type of mutation is not important. And there were 3 tumors that we identified that had mutations in both BAP1 and PBRM1. So what are these data telling us? Well, so importantly, PBRM1 was mutated in approximately 50% of the tumors, BAP1 in 15% of the tumors. So we would have expected 7% of the tumors to have mutations in both BAP1 and PBRM1. However, we only found 3 tumors in this series of 176 patients, and this is highly statistically significant. So what this data suggested to us is that simultaneous inactivation of BAP1 and PBRM1 is infrequent, and possibly that BAP1 and PBRM1 mutations are anti-correlated. We extended these findings to a meta-analysis. We are looking here at data from the Beijing Genome Institute, Memorial Sloan Kettering, and the TCGA. And as you can see, in every instance, the number of tumors with mutations in BAP1 and PBRM1 observed was lower than the number of tumors that would have been expected. So once again, it appears that mutations in BAP1 and PBRM1 tend to be anti-correlated. So we believe this establishes the foundation for the first molecular genetic classification of clear cell renal cell carcinoma. In our series, 55% of the tumors had mutations in polybromo1, and 15% of the tumors had mutations in BAP1. Importantly, these tumors were typically of high grade, and these tumors with mutations in polybromo1 were typically of low grade. Interestingly, the BAP1 and PBRM1 genes are located on chromosome 3p, where the VHL gene is located, in an area that is deleted in the vast majority of patients with both sporadic as well as familial clear cell renal cell carcinoma. So patients that have a germline mutation in VHL have a very high predisposition to develop renal cancer. Now, this has led us to propose the following model. So we believe that renal cancer starts with a mutation in VHL, and this is followed by loss of 3p. And with the loss of 3p, you lose 1 copy of VHL, the remaining copy of VHL, but also 1 copy of BAP1 and PBRM1. And we think that a mutation in BAP1 will result in a high-grade tumor, and a mutation in PBRM1 will result in a low-grade tumor. We think that this may also explain why humans that have a germline mutation in VHL are predisposed to kidney cancer, but not mice. So mice that have a germline mutation with VHL don't develop kidney cancer. Why is that the case? Well, as it turns out, in mice, VHL is on chromosome 6, but the BAP1 and PBRM1 genes are on chromosome 14. So as you can imagine, loss of heterozygosity and loss of, in this case, the long arm of chromosome 6 is still going to leave the mouse cells with 2 copies of BAP1 and PBRM1. So to test this hypothesis, we inactivated VHL and 1 allele of BAP1 in nephron progenitor cells, and indeed, targeting of VHL and BAP1 in the mouse was sufficient to cause kidney cancer. You can see here, this is a clear cell renal cell carcinoma. You can see the cells with a pale cytoplasm. You can see abnormal mitosis. These tumors tend to be of high grade. They are highly proliferative, and they stain for the HIV target, CA9. Now, this model also makes another prediction, which is patients with BAP1 mutations are likely to have more aggressive tumors than patients with PBRM1 mutations, and we tested that. So we simply look at our cohort and we ask the question, what happens to patient survival? And as you can see here, the survival of patients with PBRM1 mutations was significantly better than the survival of patients with kidney tumors that had loss of BAP1. We look at a second cohort from the TCGA and essentially found very similar results with very similar hazard ratios. So to extend these observations, we have developed an immunohistochemistry test. This immunohistochemistry test, I will not go into details, has an outstanding positive and negative predictive value. And using this immunohistochemistry test, we evaluated the major registry involving over 1,300 patients. And as you can see here, we were able to find very similar findings to what we had observed in the cohorts at UT Southwestern and the TCGA. And we are looking here at kidney cancer-specific survival. And as you can see, the outcomes of patients that have BAP1 competent or BAP1 positive tumors are a lot better than the outcomes of patients with BAP1 negative tumors, again with a hazard ratio around 3. We've also developed an immunohistochemistry test for polybromo-1 for BAP180, and we believe that based on these two tests, we can segregate kidney cancer into 4 different subtypes. These, again, using the Mayo registry. The patients that have tumors that are competent for both BAP1 and PBRM1 have the best outcomes. Then you have patients that have tumors deficient for PBRM1, patients that have tumors deficient for BAP1, and patients that have tumors deficient for both BAP1 and PBRM1, which, again, we found that they were markedly underrepresented. We would have expected 5.3% of the tumors. We only observed 1.8% of the tumors, and this was highly statistically significant. So we believe this establishes the foundation for the first molecular genetic classification of a sporadic clear cell renal cell carcinoma. We think that these tumors can now be classified into 4 different subtypes: wild-type tumors, PBRM1 deficient tumors, BAP1 deficient tumors, and tumors deficient for both. And we hope that as we are able to unravel and characterize the signaling pathways downstream of polybromo-1 and BAP1, these changes will be translated into different therapeutic approaches. To summarize this part of the talk, so I've shown you that the discovery of BAP1 and PBRM1 mutations in clear cell renal cell carcinoma has led to a new classification of kidney cancer. We believe that these 2 genes define 4 subtypes of clear cell renal cell carcinoma with survival rate estimates that range from 0% to 80% over 15 years, and these are patients with localized disease. BAP1 and PBRM1 deficient tumors are associated with different histological features, mTORC1 pathway activation and gene expression, which I have not shown you. Importantly, BAP1 is an independent predictor of outcome, and in fact, BAP1 immunohistochemistry tests are now being done in many clinical laboratories across the country. And I'm going to show you now that during this study, we found a germline variant in BAP1, which prompted us to ask the question whether germline mutations in BAP1 would predispose to kidney cancer. And germline mutations were known to in BAP1 were known to predispose to uveal melanoma and mesothelioma, and we found that these mutations also predispose to kidney cancer. So we entered into a collaboration with Marston Linehan and Charis Eng, as well as Patricia Daya, screened approximately 80 families that had a familial kidney cancer, but no predisposing mutation, and we identified 1 family where the predisposition to kidney cancer correlated with a mutation in BAP1. This is likely to be generalizable, and in fact, there was a second report around the same time from a group in Europe with the same observation that BAP1 mutations predispose to kidney cancer in patients. BAP1 germline mutations predispose to kidney cancer. Now, I put this slide here for Fred. This is actually a very productive collaboration that we have had with Genentech, looking at the molecular genetics of the non-clear cell types. These account for approximately 20 to 25% of clear cell tumors, and this paper just got reported in Nature Genetics, and Fred is a co-author on the paper. So I've talked to you a little bit about personalized medicine with the case that I reported, our efforts in the area of molecular genetics, the development of biomarkers that can help us classify patients into 4 different subtypes. And I'm going to finish off with a story on our efforts in tumor modeling. So as you may know, 90% of anti-cancer drugs entering clinical trials fail. What that shows is that current preclinical models are inadequate. And we embarked on a large effort to develop better models through the implantation of tumors from patients orthotopically in the kidney of NOD-SCID mice, immunocompromised mice. These tumors get then sequentially passaged and also frozen viable. So approximately 20% of the tumors engraft, and interestingly, engraftment correlates with poor survival in patients. So it's the most aggressive tumors that will grow in the mice. We've shown that these tumors reproduce the histology, the gene expression, the mutations, and the treatment responsiveness of human tumors in patients. We presently have 53 clear cell renal cell carcinomas, 25 that are PBRM1 deficient, 7 that are BAP1 deficient, and 3 that are deficient for both. We also have 6 papillary tumors, including 1 with a germline mutation in fumarate hydratase, and 15 other tumors. And I'm going to talk to you about the deployment of this tumorgraft platform to study novel agents. So this was my second bullet point here. So I talked to you about the discovery of new genes and pathways, which we hope that, like for VHL, will lead to new treatments. And as you can see in this slide, every protein that these drugs target, it's either a kinase or a soluble or a circulating protein. Right? So we have here the VEGF ligand, which is targeted with this monoclonal antibody, and all of these drugs are kinase inhibitors. But the most attractive target in kidney cancer is this transcription factor here, which not only regulates angiogenesis, but also stem cell and other programs. Now, there are 2 types of hypoxia-inducible factor proteins that are thought to play a role in kidney cancer, HIF1 alpha and HIF2 alpha. However, recent discoveries from Vhl and Celeste Simon and others have led the field to believe that the HIF2 transcription factor is really the more important one in driving kidney cancer development. So you may know that the HIF2 alpha gene was discovered, in fact, by David Russell, who is sitting here and who I had the privilege to be introduced by. This is actually from their original paper from David Russell and Steve McKnight's group in Genes and Development in 1997. Subsequently, structural studies performed by Rick Bruick and Kevin Garner at UT Southwestern, and Rick Bruick was last year's O'Donnell recipient, identified a small cavity within the HIF2 alpha PAS-B domain that they thought could provide a foothold for drug development. So they did a screen, and this screen identified small molecules that fitted within the cavity and disrupted the binding of HIF2 alpha to HIF1 beta, which is essential for DNA binding and transactivation. This led to the founding of a company, Peloton, and Peloton has come up with a drug. They received the IND approximately 3 months ago or so, and this drug has now entered phase 1 clinical trials. So we are looking at an analog of this drug in our tumorgraft mice. So again, the expectation is that this drug or the analogs will bind to the HIF2 alpha protein, specifically to this cavity in the PAS-B domain, will disrupt dimerization and will block gene expression. So I'm going to show you just one slide of data. And I don't know what happened to my mouse, but this was supposed to be a mouse, and this is the kidney. You can see a kidney tumor over there. What you are looking at here is a Western blot of an immunoprecipitation from, in fact, one of the tumor grafts. So we've now evaluated 20 different tumor grafts from 20 different patients. So this is a tumor graft that has been treated either with vehicle. So the tumor graft bearing mice were treated with vehicle or with this HIF2 inhibitor. And we've then done an immunoprecipitation for HIF1 beta, which is a shared subunit between HIF1 alpha and HIF2 alpha. And as you can see, when we pull HIF1 beta, we can pull HIF1 alpha, and we can also pull HIF2 alpha. But in these 4 mice that have been treated with the HIF2 inhibitor, we are unable to bring down HIF2 alpha. So the HIF2 inhibitor is able to specifically dissociate HIF2 alpha from HIF1 beta. So we are using this platform for biomarker discovery and to anticipate mechanisms of resistance, as we heard during the first talk. So I'm not going to go through the other pillars of the laboratory, but suffice to say that we believe that this is a powerful pipeline to get to personalized medicine. If you are interested, you can go for more information to our website, and I will finish off by acknowledging the people in the lab and elsewhere that did the work. So Samuel Peña-Lopez was the lead investigator in the BAP1 story. Sharanya, Vanina, Andrea, Ebony, and Haley, who is missing here, take care of our tumorgraft platform. Wenfang is involved in the work with the HIF2 inhibitor. Yifeng is similarly involved with that work. And Renee McKay is in the laboratory and helps me with the supervision of the laboratory. Payal is the pathologist that we work very closely with. Megan was the lead author of the paper that led to the discovery of BAP1 mutations in the germline. We've worked very closely with a team of investigators at Illumina. We've had a very productive collaboration with Mayo Clinic, where we've been able to access samples from their repository, from their registry for analysis. We have also a very nice collaboration with Genentech, and we collaborate with NCI and obviously Peloton Therapeutics, and those are my sources of funding. Thank you for your attention.
We have time for a couple of questions. Dr. Brugarolas.
So you have this observation that BAP is anti-correlated with mutations in a switch SNF component, BAF180. Other switch SNF components have also been found to be important in this cancer, like BRG, BAF250A. Are they also anti-correlated with BAP1 or perhaps anti-correlated with each other? Because BAF250, BAF180 are in different kind of switch SNF complexes.
Mm-hmm. So excellent question. So for reasons we don't understand in clear cell renal cell carcinoma, the polybromo1 gene is mutated way out of proportion compared to the other subunits. And it's also very interesting that there is another subunit of this switch SNF nucleosome remodeling complex that is telomeric to PBRM1 on 3P. So even though you're losing 3P in the vast majority of tumors, that gene is very rarely mutated, which suggests that there is some specificity to these different subunits. And it may have to do with the importance of the PBAF complex that PBRM1 is specific for. But I think that's a very interesting question.
Thank you. Do the BAP1 mutations correlate with metastatic site specificity?
So excellent question. And again, congratulations. I mean, you guys were involved, work with the TCGA, also in clear cell renal cell carcinoma was outstanding. BAP1 mutations have been correlated in uveal melanoma with metastases. That's unequivocal. In renal cell carcinoma, I show you the data that in patients with localized disease, if we look at kidney cancer-specific survival, those that have mutations in BAP1 have a significantly higher chance of dying from their kidney cancer than those that don't. So we are in the process of doing now 2 additional sets of experiments. One is we are comparing, which may get indirectly to your question, the rate of BAP1 loss in primary tumors and metastases. And 2, we are looking at the impact of BAP1 mutated tumors on survival after the tumor has metastasized. If BAP1 were to be implicated exclusively in the process of development of metastasis, you might expect that patients with BAP1 mutated tumors would have similar survival as patients without mutations after they present with a stage 4 disease with metastasis. Does this address your question?
I guess we don't know the data yet, right? That's the real answer.
Right. So those 2 studies are ongoing.